All right, so anyway, my topic that I was given was the Watchman, and thanks everybody for being so attentive. Okay.
It's better.
All right, thank you. If you got to figure out how one of these works, you should be able to do this before you can do the procedure. But in any case, do I need to kind of point it at that, or?
Chris, why don't you do advance?
Yeah, why don't we just, next slide, yeah. Anyway, this is a device that has an interesting history. I actually trained in learning how to do it a couple of years ago, but because we thought that the device was going to be released. Can I have the next slide? Yeah. What happened was the FDA kind of held things up. They wanted more data, more information, that sort of thing. So it's really been a couple of years since I trained on it. But the difference, and I just want, while we're killing some time here, I'll just tell you that the technique, and Niraj is still here, or David's here. But anyway, the technique for going across the septum has to be a little different with the Watchman than what you guys do, because you got to have a straight shot at the left atrial appendage. So it's a little different technique going in, and you quickly adapt to that. But it's just a difference in the positioning of the catheter, because it's a lot bulkier device. It's not forgiving, you know. So you have to kind of be straight across into the left atrial appendage. And what we do is we do this procedure, or we will do it. I'm thinking it'll come probably last quarter of this year, maybe first quarter next year. We do that in conjunction with an electrophysiologist. So in other words, you know, you have an interventional guy and you have an electrophysiologist, because we are not as skilled as they are at all in doing a transeptal puncture. I mean, they do it every day. But in any case, the technique involves basically, well, might as well talk to you about it. Remember, most clots are in the left atrial appendage that become embolic. So if you want to block clots from going from the left atrium up to the brain or up to other parts of the body, then you try to occlude the left atrial appendage. Now, our surgical colleagues already do that. Don't you all do that a lot of times? You ligate the left atrial appendage?
Yeah, there's several different ways you do it.
Right. And they know that when they're doing surgery, if they want to reduce the incidence in a patient with atrial fibrillation of future embolic events, they'll close off the left atrial appendage, and that will greatly reduce the incidence of systemic embolization. So in any case, we talked about before matching up the Has-Bled scores to the Chad-Vask scores. So in other words, the ideal patient for this is going to be somebody who has a high Has-Bled score and has a high Chad-Vask score. So in other words, they're highly likely to embolize with atrial fibrillation, but they're also highly likely to bleed from anticoagulation. Now, I do have one question for everybody. Does anyone know what Has-Bled stands for? I had to review this myself because I couldn't remember it. Anybody want to take a stab at it? H-A-S-B-L-E-D. I may not even remember it myself, but it's hypertension. A is abnormal liver and renal function. It's not age, it's abnormal liver and renal function. The S is stroke. The B, bled, is for bleeding tendency, or bleeding diathesis, you know, a patient who can bleed easily. The L is for labile INRs. The E is for elderly. Now, the definition of elderly, as far as I was taught many years ago, is 35 years older than the physician giving the talk. So I strongly object to, I'm not there yet at 65, but I strongly object to the use of elderly and 65 in the same sentence. And then D stands for drugs. And those drugs could be a person who consumes a lot of alcohol, a person who's on platelet medication, aspirin, that sort of thing. So that's Has-Bled. So when we're talking about that, at least you all know, you know what we're talking about. So in any case, and we will be discussing a couple of trials here, but remember, to get FDA approval for any device, you have to have a big trial, you have to have it randomized, you have to have goes before a subcommittee of the FDA, then goes to the FDA, and when they roll out a device, the device will be rolled out to centers that already have the IDE for that device. Now, I was involved in a lot of this at St. Joe's, but none of it at Gwinnett, because we just haven't had an active research program. I assume we're getting that underway now. But in any case, so the centers that had the IDE For the Watchman, we'll be doing it first, and that's so the company can get a good track record when something's released, and then it'll be rolled out to other centers like ours in Gwinnett, and I assume somebody in Athens will be doing it. Sabot, have you heard? Is there anybody? I'm sure there's some people with interest there. Yeah. So, but that'll be, if they weren't in the original research protocol, it will not be rolled out to them right away. So just like us, we'll have to wait. Probably people are getting going now about third quarter, and we'll probably wait till fourth quarter, I'm thinking, of this year. We still frozen there? Okay. All right. In any case, let's see how we... So the Watchman, Rick, do you have any experience with that? Or
why they call it Watchman?
I can't remember. No idea. You'll have to watch, man. I don't know.
I know what it is, I've seen it, but I have no experience.
Yeah, I mean, it's very similar to when we use an amplat occluder to close up an ASD or a PFO. It's like a half of an amplat occluder, basically. And we won't get into the technique in my presentation of putting it in. We're just going to go over the trials. But basically, it's kind of a half of an amplat occluder that you would put on either side of the atrial septum. And it's a pretty bulky thing. I mean, it's not a small little device that kind of sits in there, you know. And the idea is to get a good seal. You put a little dye in to outline where the left atrial appendage is, and you see a lot of trabeculations. Very funny looking. Do you guys ever do that, inject the left atrial appendage with contrast? Or? Oh, okay. But anyway, this technique requires that. And you can see all the trabeculations and all the ridges in the left atrial appendage. And then you put the device in there, and then you look to see if there's a good seal. And we'll use the term seal in this presentation because you want to make sure that you know, if contrast is staying in there behind the device, then you also can't get clots from around that device. So in any case, these are, just hit this, okay. So these are all, this information is stuff that we've already talked about, but in non-valvular atrial fibrillation, greater than 90% of stroke-causing clots that are formed in the left atrial appendage, 90%. The Watchman evidence-based medicine pilot study, and where I came in learning about this was around 2013 at TCT, our yearly angioplasty meeting. And then I skipped any trials on it last year because there was, we weren't sure if it was even going to be released. And then, you know, this year, fortunately, the FDA panel and then the full FDA approved it. All studies, favorable procedural safety profile for 7-day safety events. Protect AF was a big trial. CAP, Prevail, CAP2, we'll get into all those. Primary efficacy endpoint, you're talking about events per patient years, because you have to do that, because if you're not studying something for a lot of years, you know, you're going to have to go by patient years and you have to use curves. And you can see that comparing the device to warfarin, and if you look at the non-inferiority and superiority, look at the, I asked you to focus in on the posterior probabilities. Is it a big circle is the pointer? I don't want to press the wrong thing here. Okay. If you look at the non-inferiority, 99%, superiority, 96%. Protect AF, 40% lower, primary efficacy, all stroke 32% lower, cardiovascular unexplained death, hard point, lower, disabling stroke lower compared to warfarin. If we look at the CHADS VAS score and Protect AF and CAP, these are fairly high scores. So these are risky patients. I mean, that's the kind of patients that we're talking about. Remember now, generally speaking, the patients, and anyone here in the room, correct me if I'm wrong, but generally speaking, the more complicated the patient is and the higher CHADS score, the more likely they are to bleed. So I mean, those higher numbers, you're using a device or you're using a drug to prevent stroke in somebody who's a high risk for stroke, but they're also the highest risk patients for bleed. The Prevail trial, primary endpoints, safety, occurrence, death, ischemic stroke, systemic embolism, procedure or device-related complications. And that's our always, for an interventional guy, that's always our bugaboo, is we're leaving something in there and we got to make sure it's in the right place. Primary efficacy, similar 18-month event rates in both device and control groups. Secondary primary efficacy comparison of ischemic stroke or systemic embolism, endpoint met, in the presence of an overperforming control group. Protect AF, CAP, and PREVAIL, all very similar. Free from efficacy primary endpoint, time in years, and you can see a very, very nice curves there. If you look at these hazard ratios are very, very simple to present data this way. In other words, the more it goes to the left, the more it favors a treatment, and the width of the line will show you the confidence limits. So in other words, the shorter the confidence limits, the more confident you can be that that's a good number. And if we look at the mean CHAD scores, these are high scores here. So these are complicated patients that we would expect if you can use this device. And if we look at ischemic stroke rate, trial warfarin arm. 150 atrial fib patients contraindicated for long-term warfarin therapy. Patients had a history of hemorrhagic bleeding tendencies. 150 patients at 4 European centers. As usual, Europeans are always ahead of us. It's easy to get things approved there. Reduction in ischemic stroke versus expected rate. Some very nice reductions. 7.3%, 5% expected if clopidogrel was used throughout follow-up, and the observed rate was 1.7. And Watchman pilot study, 6-year follow-up. So here's a study where we have some good follow-up. It's not going to be big numbers, but in any case, 2 embolic strokes over 6 years of follow-up. 90% reduction when compared to a CHAD's expected stroke rate. So 90% reduction. These are the major trials that were done with the Watchman, and early feasibility, primary efficacy, cardiovascular death rate, disabling stroke, superior to warfarin, significantly improved safety results, efficacy consistent with Protect AF, expected rate of stroke reduced by 77% in patients contraindicated to warfarin. That's a nice number. Remember, warfarin was about 60, 65%, wasn't it, on reducing strokes. Improved implant success, and consistent procedural safety results. And before we start doing it, we'll have to bone up on I'm sure, there's been some newer techniques. This one we're going to test you on afterwards. But anyway, let's see. Yeah, I think we've already talked about all this. These were some of the earlier slides. But this is atrial fibrillation creates an environment for thrombus formation. And this is what our colleagues see when we look at the heart with the ultrasound. Treatment guidelines, this is just a little review, but annual stroke risk 1%, oral anticoagulants or aspirin may be considered. Annual stroke risk 2 to 15%, oral anticoagulants are recommended. There's one thing I did want to mention. I'd like David to comment on this, or Subodh, or Marty, either one. In the Averroes trial, aspirin versus apixaban, very similar stroke rates, very similar bleeding rates. So these were patients who were not thought to be candidates for oral anticoagulation, were given aspirin, but when you gave them apixaban, it worked. So this was giving apixaban to those people we never think should get.
The stroke rate, the bleed rate.
A little bit higher. 1.5 versus 1.3, something like that. Yeah. No, it was not. It was not. It was a little higher.
The issue is just that the number of events was so small.
Right, right. But it was a very low, yeah.
Go back to the previous slide and explain that picture of TTE.
Oh, okay. All right.
And how do you get that? And where's the problem?
Okay. Okay, so this is the left atrium right here. And and there's our thrombus.
From the esophagus.
Yeah,
right?
yeah. Because wherever, remember, this is a pie shape, so wherever you have your transducer, the sound's going to go out like a pie. So you know that your left atrium is right back against your esophagus. In the old days, what I was taught in med school was that people would present with dysphagia when they had big left atrium, some mitral stenosis that was untreated for many years because the left atrium would enlarge and poke up against the esophagus, and they'd have trouble swallowing. So that gives you your best look at the left atrium. For some reason it was moving before. I don't know what happened there. Oh, here it is. Okay, all right.
And the clot is sitting there where?
Yeah, that is
That's a clot.
I can't say that's the atrial appendage there. But I can't say that's the atrial appendage, though. I mean,
That is the appendage.
that is the appendage right there? Yeah, yeah, okay.
And that's
All
when
right.
the watchman does it, close the door.
Close it, seal it off. Yeah.
So if that's an organized thrombus, how long has it
Who knows? Who knows? But as, you know, the body's own lytic system, little pieces will come off and, you know. Oral anticoagulation standard of care, not ideal for all. Bleeding risk, daily regimen, high non-adherence rates. The NOACs, bleeding risk, daily regimen, high non-adherence rates. Complicates surgical procedures, high cost. Anticoagulant therapy carries a risk of intracerebral hemorrhage or death. Right there's blood. Blood. Anticoagulation, despite increasing NOAC adoption, the overall rate of anticoagulation in high-risk patients has not improved. So in other words, if you look at the rates of anticoagulation, and I think Sabode was alluding to this when he was talking about we ought to monitor our own practices. Study drug discontinuation rates are high. Major bleeding rates are high. There is an unmet need for stroke risk reduction for patients in AF seeking an alternative. And the Watchman, and this is the device right there. You know, Niraj, I was kind of comparing it to like half of an Amplatz occluder for a ASD or a PFO, you know. That's kind of what it is. It's kind of that same, like almost like a parachute that kind of fits in there. And this is, we had kind of gotten interrupted with our presentation. But anyway, I'll stop there. Are there any questions?